So my name is Aditya Vinjamuri. I'm a third-year medical student at Tulane School of Medicine, and my project is called Can Inhibiting Ferroptosis and Subsequent Endothelial Glycocalyx Shedding Reduce the Morbidity and Mortality of Hemorrhagic Shock? So this is a trauma-based project. So a little background. Trauma is the leading cause of death in people under 44 years old, so relatively young people. Hemorrhagic shock is a consequence of trauma and contributes to the morbidity and mortality in these patients. And shock-induced endotheliopathy has recently garnered a lot of interest due to its effects of endothelial glycocalyx shedding, which may promote coagulopathy following hemorrhage. And we know that succinate accumulates in tissues during hemorrhagic shock due to electron transport chain uncoupling, and is a direct and indirect and independent predictor of death due to its promotion of ROS. So we hypothesized that this novel administration of lyproxtatin-1, which is a ferroptosis inhibitor, prevents the buildup of succinate and reactive oxygenation species and promotes better physiological recovery following hemorrhagic shock. So here are some goals of our project: to determine if lyproxtatin-1, a ferroptosis inhibitor, can reduce glycocalyx shedding in hemorrhagic rats, providing evidence of its therapeutic value in the setting of hemorrhagic shock. So in the past, ferroptosis has been studied in the setting of cancers and other diseases, but it's never been looked at shock, septic shock, or anything that is ischemia reperfusion, in the setting of ischemia or reperfusion. So we hypothesized that if we're able to prove that there is a protective effect or there is something going on, that it might cause other people to look into it and see what other settings does this novel ferroptosis thing like have an implication in. So just looking at some vessels, this is some background. On the left here, this is a vessel in the lung which has a glycocalyx, and the glycocalyx is the green stuff sticking out into the lumen of the vessel. So when it's hemorrhaged, this glycocalyx gets shed and is no longer visible. And that, we think, is the reason of coagulopathy or promotes coagulopathy. So we're looking to see if lyproxtatin-1 can prevent that shedding and thereby reduce morbidity and mortality. So these are some of the methods that we used to carry out the experiment. A rat model of hemorrhagic shock and resuscitation was used to assess glycocalyx disruption via fluorescent labeled staining. A control group of 5 was resuscitated only with lactated ringers. An experimental group of 5 was resuscitated with lyproxtatin-1 and then lactated ringers up to a certain blood pressure, 40 to 60 usually, 40 being the hemorrhaged map and 60 being the resuscitated map. A control group using styrene, which is a DMSO-like solvent, was also used. We had to do this because DMSO was the only thing that could dissolve lyproxtatin-1, and this is the next best thing. It's an organic version of DMSO, so it has a little more biosafe profile, and it's not as toxic or so to the tissues as DMSO. And we know that DMSO does have an effect on its own, so we want to evaluate if styrene has an effect on its own as well. So in the experiment, rats were exposed to conditions of hemorrhagic shock and maintained at 40 mmHg for about 30 minutes. Experimental groups received the lyproxtatin-1 prior to resuscitation, and after the 30-minute period, both groups were resuscitated with lactated ringers up to 60 mmHg or higher, depending on what group they were in and how much they rebounded to. So syndican-1 is a known constituent of the glycocalyx, and we were able to measure this using an ELISA, and that's our direct measure of how much shedding is happening and how protected the glycocalyx is. So all the tissue samples were taken from the right lower lobe of the lung and were analyzed with immunohistochemistry. So here are our results. So glycocalyx shedding was significantly lower in the lyproxtatin-1 treated group compared to control group. So this is the no drug. So this is our control group, and you can see that the shedding measured by syndican-1 and succinate and glycocalyx shedding is much, much higher compared to lyproxtatin-1, which didn't really go up at all, not significant at all. So just based on this result, this preliminary result, we were quite excited about the prospects of this drug and what it could do to prevent some coagulopathy in the setting of hemorrhagic shock. So these are some images that we took of the surgery and the experiment. This is an arterial line. So this is the femoral artery, and this is blood being drawn out of the femoral artery. So this is how we do our controlled hemorrhage. This is how we do plasma or blood serum collection to then get the serum, or spin down and get the serum rather. And this is the jugular vein. This is how we dose the drugs. So this is how we infuse directly in. And as you can see, like we can't have any air bubbles. And there are some other factors playing into the dosing rate and the dosing concentration that we were doing, and that I'll touch on in a few slides. So here's some more images. This is another jugular vein. This is how the dissection of the femoral artery looks from a low magnification and then a high magnification when the catheter is inserted and clamped off. So, thanks. So just looking at from a macroscopic level, if you're looking at the physiological conditions of the rats while we're doing this experiment, the rats treated with lipoproxatin 1 had significantly better mean arterial pressures compared to control rats, which did not receive lipoproxatin 1. And as you can see, it's about 20 mmHg, a little less than 20 in 15 minutes, and it even grows to about like 30-ish for 30 minutes post resuscitation. So just looking at this, that we know the rats are better off physiologically, even though they're anesthetized, they're able to hold a much better blood pressure and they look physiologically better compared to controls. So this result again made us very excited about, hey, is this drug like a miracle drug, and does it actually have a therapeutical value in this context? So another yes. So what are the implications that these experiments prove to us? We know that ferroptosis inhibitor lipoproxatin 1 can acutely reduce morbidity during hemorrhagic shock and can protect the endothelial cell membrane from oxidative damage due to its ability to slow ROS generation and lipid hyperperoxides. So treatment with lipoproxatin 1 in vivo provides evidence of its ability to reduce morbidity and subsequent mortality by reducing glycocalyx shedding and preventing coagulopathy. So some of the discussion things that we need to bring up are, oh my God, again. When we first dosed with the Cyrene and lipoproxatin 1, we dosed aggressively and we dosed a very concentrated amount. And when we did that, we noticed that the hearts were giving out. The rats would look fine for a minute or two, but then they would get like acute dyspnea and then just start decompensating very fast. So when we opened up the rats, we noticed that the hearts were actually infarcting. And you can see on the bottom heart here, it kind of looks like a pale infarct, kind of like a myocardial infarction we'll see on pathoma. But we were kind of concerned, like this drug does so much in vivo, but why is it that it's causing this at really high concentrations? So to get around this, we diluted it down by a factor of 3. So when we dose the drugs, I dose them over a course of 5 minutes, and I dose a much lower concentrated amount, and that seems to be making it much better for the rats' bodies. As you can see on the upper image, the heart, there's no pale areas or weird striations that you can see. That shows the heart is exactly how it's supposed to be. So further experiments are going to be completed to complete the experimental groups. So 5, 5, and 5. So a total of 15 rats will be completed. Additionally, we'll have to take all those samples, stain them, and then evaluate for glycocalyx disruption to visually look at what is happening. And not only the lipoproxatin and hemorrhagic and HR control group, but also in the Cyrene, just to make sure there's no therapeutic effect of Cyrene and that it's truly just acting as a vehicle. And I think that was it. So if we have any questions.
All right, great, Aditya. Thank you so much. Yeah, I was kind of interested in the toxicities, but you kind of touched on that at the very end. So it was interesting that you kind of found a balance there. Any other findings in the rats, kind of as far as even once you've diluted it out by 3 times, or were they? kind of carrying on as normal before you dissected?
They were kind of carrying out as normal. The major finding I would say is that elevated blood pressure. So usually we would resuscitate them from 40 all the way up to 60. But then when we gave the liproxatin 1, they would already be at like 67, 70, way past the threshold that we would be trying to get them to, the control rats. So when we actually resuscitated with additional LR, they actually went up to into the 80s, sometimes 90s, and they looked like they hadn't even been hemorrhaged. And that's what was really so striking about the experiment.
So moving forward, are you going to go with the same concentration? Or are you going to go less, or what do you think?
I think we're pretty good with the concentration we have currently. We're doing 0.2 mgs per kg, but I think the important part is spreading it out over like 4 or 5 minutes. If you do a volume load too fast, I think that's what's causing some of the cardiotoxicity. But if done over a slow infusion over like 5 mils over 5 minutes, so a mil a minute, I think the hearts are able to tolerate that, and we aren't having any weird issues.
Fantastic. Thank you.
Thank you.
All right.